great. I think I'll make my comments from here, if that's okay. I think that was a fantastic overview of some of the stuff of the law. I'm still learning so much about the law, and I guess there's a lot to learn. What I want to do is maybe just reflect a little bit on some of the things of what I've experienced around this as a physician, a little bit involved with it, and then just lay out some of where I think we are and where we're going. And I guess if I spoke Italian and could say what the Affordable Care Act is in Italian, we'd have the title of a new opera, because I think this has had all of the elements of a fantastic opera. I mean, the twists and turns of getting this law passed and has been just extraordinary. I mean, going back to how it was initially passed, the Scott Brown change, how the House and the Senate had to reconcile their differences, and it's just has gone on and on, including, like you mentioned yesterday. I had CNN on and thought for a couple of minutes, thought it was over, right? And then, in fact, it came back again. It's like Al Pacino, right? It's like, just when you think, So it's got all these twists and turns to it that are, just extraordinary. And I actually want to reflect on that a little bit, because I had really was given a fantastic opportunity because of a fellowship of the Robert Wood Johnson Foundation that provides opportunities for mid-career health professionals to go work with members of Congress, and my timing was impeccable because I was able to show up in the fall of 2009. But what became immediately obvious to me that was so different about that world compared to my world of doctoring in the hospital is, when I sort of simplify what my life is and going on ward rounds, and we see patient in the bed, and I turn to the residents and I say, okay, the plan today is we're going to give a little more Lasix or a little less this, and that's pretty much the end of the discussion. I mean, there might be a little feedback from the resident that said, hey, had you thought about this antibiotic or things like that, but we pretty much reached closure. And I found in my time in the Congress that it never seems to end. I mean, ever you have a discussion, you think you've got everyone on board, and there's a remarkable ability for the conversation to go on and on and on. And I mean, I continue to see that now. It was mentioned in the beginning that I've had an opportunity to continue to do some consultative work with the Secretary's office around some of the regulations and implementation, and some of the same battles that I thought had been raised and addressed and answered continue to be raised and re-raised and so forth. And even yesterday, I think you heard many who were not as happy about the decision of the Supreme Court saying, this is not over. And I'm getting the feeling it might not be, because there's just a tremendous amount of passion here. Having said that, I did feel from many friends and colleagues just an incredible outpouring of emails and phone calls and so forth. And there was a little bit of sense that I had that, this law went up against a pretty big fight in the Supreme Court, and it came out pretty much unscathed. It's sort of like, a great sports figure underdog who had to beat, a tough team or something, and won in the end. And I just have a little bit of sense that it maybe warmed the hearts of those who wanted to love this bill. Maybe some of you here in the audience a little bit more, and because there's been an ambivalent relationship around this law, maybe almost like people who were afraid to embrace it because it was going to get overturned again in some ways. So. Anyway, I just feel like maybe a very significant turning point has happened, even though I don't think the fight is necessarily over. I do want to bring just really simplified focus to make sure we understand why the mandate was a big deal about this yesterday, and to make sure that the kind of what I think of as the triangle of what is at the heart of this bill, of this law, what was all about. And if you think about it in the following ways, which is that there was pretty broad consensus across the Congress that individuals who were sick or in need of health care were ironically the same people who were having so much difficulty getting health insurance. It just didn't seem to make sense to a lot of people. Pre-existing conditions became the barrier to getting the thing that you thought people needed. And so there was a desire to sort of say, listen, health insurance companies, this cannot go on. We need to make it so that everyone can come in. And health insurance companies said back, I don't know what the tone of their voice was or how they expressed this completely, but they said something along the lines of, well, the problem is we notice the people who come to buy our products know something about their health, and we're worried that they're the really sick ones, and so there may be a lot of costs behind those individuals stepping forward. It isn't just healthy people saying, gee, I'm being careful for a rainy day. They thought there was disproportionately sicker people coming forward. And the idea of the individual mandate was to say, you know what, let's have the same starting line for everyone. Let's get everyone into this to make sure that it isn't selection on the basis of health and that everyone would come in under this roof. So that sounded like a good thing, except people then remembered health insurance, that's a pretty expensive product. And so if we're going to force everyone to get this, we need to have a way to make sure that those who can't afford it are in fact able to do that. And what I think you just heard so eloquently described is there's basically two ways the federal government is doing this and is investing in helping people up to 400% of the federal poverty level, which is about $90,000 for a family of four, to help them buy insurance. Half of that group, essentially up to 133% of the federal poverty level, will come into the Medicaid program, notwithstanding some of the issues that were just raised about whether some states will make that harder or not, and the other half through the exchanges. And when you're in the exchange, if you're between that 133% of federal poverty and 400% of federal poverty, the government on a sliding scale basis is going to help you buy insurance. And if you're at the low end of that income sliding scale, they're going to pay almost all of it, right? So they're going to help very low income people buy private insurance to come in. But even up toward $90,000, there'll be a little bit provided to help people to make this more affordable. So that's the three pieces that had to come together. And without the mandate, there was, of course, the fear that if it didn't require everyone to get insurance, that we'd be back in that situation of only the sickest people coming forward to buy insurance, insurance companies then on a cycle of continually raising the prices, and as the price goes up, the healthier people dropping off. This was known as the death spiral, if you will, of health insurance, and so that's why the individual mandate makes sure that we all stay in the pool together. So that was a critical part of the decision yesterday and why it was so conceptually important. Now, in terms of what happens next, what mostly the discussion has been about a coverage expansion. And in fact, the Affordable Care Act, in its the main parts of it are about coverage expansion. It does also address a number of things about the delivery system that we can talk about today as well, things like accountable care organizations, primary care medical homes, new ways of paying providers to bundle payments together in ways that will try to promote more efficient ways of delivering care. But really the majority of this legislation is about expanding coverage. And if it's fully implemented and working as planned, we will be up around 94 or 95% of our population covered through either their current coverage and then how it will be expanded to cover them. But what we care about most is not just getting people health insurance cards. We want people who need to be able to go to the doctor, who need to come to hospitals, who need to be in nursing homes, who need different parts of the health system to be able to take advantage of those. So it's about turning coverage into access. And this is, in fact, where we are right now. We got the check mark yesterday to continue to proceed forward with the coverage expansion, but we still have a lot to do to make sure that we can get this thing implemented in a way that will expand access. And for all of you in the audience who want to roll up your sleeves and get involved, the ACA is not self-implementing. Everyone needs to get involved. This is that there's a lot of things that have to happen. And just to sort of give some examples of that, there's very complicated issues that the state is currently working on between the exchange and the Medicaid program, so that when individuals come forward and say, hey, I heard the government said I need to get insurance, which door do I go in? And the idea is to create no wrong door, so that we can figure out on one simplified way what your income qualifications are. Do you end up going into the Medicaid pool? Do you end up going into the exchange? How much money will you get from the federal government to help you buy insurance and so forth? And so that's a big IT program that's underway with the idea of really trying to simplify that so that people can come in and get that coverage. But then once they have that coverage, where are they going to go to get care? We start off in California right now, as is true in many parts of the country. We have been facing a declining interest in fields like primary care, or the front line of getting people into healthcare. And so we need to make sure there are going to be doctors available to take care of many people who have probably put off taking care of their health problems for many years, right? If you had financial barriers, you probably let some problems wait on the side so that you could continue to buy food or other key essentials in your life. Now, if you have health care coverage, this is the time that individuals will show up at doctor's offices, and so this could, in fact, increase some demand on primary care and other parts of the system. And so it's critical that there be in place enough providers, and that's going to vary tremendously by region. We do know this. We are blessed here in San Francisco in many ways of having a good number of physicians and other health professionals, fantastic hospitals like UCSF Medical Center and so forth. But many parts of this state, the places in this state where the majority of people are going to come into coverage, places like the Central Valley of California, are the exact same places where there are real shortages of primary care and specialist physicians. And so we really need to think about how we promote getting providers to be in those places and to provide care efficiently so that the coverage truly turns into an access expansion. And the state has a role to play in this. I mean, part of the reason, for example, that the Medicaid program, which is a real foundation piece of this expansion, does not have the full participation of physicians and hospitals throughout our state is because California has made choices about paying its providers relatively low rates. In fact, the state of California is among the very lowest payers in the Medicaid program, in the Medi-Cal program. And this, in fact, dissuades many providers from participating in the program. There is a provision in the Affordable Care Act that will require the state to pay 100% Medicare rates to primary care physicians in 2013 and 14 to try to encourage them to expand their capacity to take on Medicaid patients. But we need to do even more than this to make sure that we're going to have adequate capacity. And let's not forget that the ACA is not the only stressor on the needs that we have for health care. Our population continues to age, and as a result, there's more need evolving and developing in our population. And clearly, we need to invest in more efficient ways of delivering care and focusing on preventive care to try to, in fact, reduce the demand for a treatment of chronic illness and the like. So I want to just, I guess, stop at my comments and say a shriek of hallelujah. I think this is a tremendous step forward. I'm very excited that we live another day to be able to continue the discussions about how to implement this successfully. I'm very thankful that I live and work in the state of California, which has been extremely proactive in moving ahead and trying to implement this, had the courage to say from day one it was going to try to set up its exchange, has worked through other Medicaid waiver programs with the federal government to get resources to help public hospitals and the UC hospitals to have some additional resources to prepare for expanding capacity and working on improving its efficiency and delivery. And I'm sure my colleague, Dr. Adler, will have some comments to say about that. But this is a great opportunity in front of us. We've been given the life to go on with it, and I just hope that as many of you as possible are able to contribute in the process. This is a real opportunity to send a message of equity and social justice throughout our population, and making sure that health care is a right and that everyone is given the best chance to have the best health to pursue liberty and happiness and all those wonderful things in America. Thank you.